Okay, well, good morning, good afternoon. Welcome to our 23rd webinar session. Today's session is supposed to focus on, well, the title is Maximizing the Global Impact of PrEP in HIV Prevention towards the UNAIDS fast-track targets on PrEP coverage. This is coming from the high-level meeting on ending AIDS. As most of you are probably aware of, the UN General Assembly held this high-level meeting on ending AIDS, which resulted in the approval of a political declaration on HIV and AIDS, on the fast track to accelerate the fight against HIV and to end the AIDS epidemic by 2030. So to discuss aspects of this declaration related to prevention and to PrEP specifically, today we're honored to have three colleagues discussing with us here at the webinar. I'm talking about Doctors Rachel Baggaley and Ioannis Metsmeletzis from the HIV Department, WHO Geneva, and Dr. Rosalind Coleman from UNAIDS Geneva. So, concretely talking about Rachel, I'll introduce her. She is, I mean, many of you guys know her, but she is currently leads the HIV testing and prevention work for WHO, including the development of policy and WHO guidelines on HIV prevention, diagnosis, treatment, and guidance for key populations. She also oversees the work on HIV prevention and recently led the development of new WHO PrEP guidelines and the work on PrEP implementation. Ioannis Metsmeletzis, on his side, he's an HIV molecular epidemiologist and biologist by training, based in Geneva, currently consulting on PrEP at the WHO headquarters and involved in supporting countries around the technical and programmatic issues around PrEP implementation. Finally, Dr. Rosalind Coleman is a public health clinician who began her HIV career in South Africa and is now consulting with UNAIDS Geneva, working on PrEP advocacy and access, with a particular focus on country policy and regulatory aspects. So really, we're going to have a sort of a broad presentation on various aspects of PrEP and the kind of work that is being done in WHO and UNAIDS in Geneva. And, you know, we're going to have Rosalind and Ioannis speak first, and Rosalind will close. And probably at the end, we'll have about 15 minutes to discuss or answer questions. So if people have questions, please use the chat window within the side screen, the GoToMeeting side screen, to write them down. And remember, we have this session is going to be recorded and it's going to be uploaded and distributed later on, no? Today or tomorrow. So anyway, again, thanks a lot, Rosalind, Ioannis, and Rachel for being here today. And we'll start with Rachel as promised. So Rachel, please go ahead.
Thank you very much, Carlos, and it's a great pleasure and privilege to be able to be part of this webinar. So thank you very much for arranging it. As you rightly said, the HLM has just happened, and I think quite a sobering report came through from UNAIDS right at the beginning of the HLM, showing that we've done really, really remarkably well on treatment. We've got huge numbers of people across the world on treatment, and this is a fantastic success, and we really need to celebrate that. But more soberingly, we still need to concentrate on prevention because this increase in treatment hasn't led to what we'd anticipated and hoped for, which is a decrease in incidence. So really, I think we need to continue to prioritize prevention and reinvigorate prevention. And PrEP is one of the possibilities to help in this reinvigoration of prevention, particularly for those populations with ongoing high incidence, key populations, and women and heterosexuals in very high incidence settings. So WHO made this recommendation last year, an enabling recommendation to support the offer of PrEP as an additional prevention choice. It was not population specific, really, for anybody who remains at substantial HIV risk. And we know PrEP is not going to be for everybody, so PrEP must be offered within a combination prevention context and with support to make it safe, acceptable and effective. And since we made that recommendation, we at WHO have really tried to support the knowledge of this recommendation amongst countries, and we've had many meetings in all regions really sharing this recommendation with people, and we keep coming across these barriers of why we can't do this. It's going to be too costly. We should involve supporting treatment first, because treatment is going to save lives, and this should be our main priority, which of course is hugely important. People in ministries worry about the safety, people worry about drug resistance, people worry that people on PrEP will abandon condom use and start having many more partners, and then there are concerns about pregnancy and interactions with hormonal contraception. These are recurring themes with all our discussions with ministries. And so we really wanted to support countries to think about PrEP by developing implementation guides. Just to give you a snapshot of the work that we've been doing over the years with our support from the Bill and Melinda Gates Foundation, is really to look at PrEP implementation projects, and I'm just going to highlight a couple here. India amongst sex workers, and most recently in Mozambique, an interesting project there to support PrEP for a short term for partners and wives of minors when they come back from the mines in South Africa, and their partners often want to conceive, not certain about their partner status, PrEP could be a way that they can have sex safely during this period. And so with this context, and as I say, with all the issues that come up and the questions countries have about how can we do this and how can we overcome the problems, we're now working on implementation guidance. We've decided on a kind of modular approach for this guidance, so it's going to be a kind of toolkit, and it's going to be centered on a range of different people who will make a difference in providing PrEP. So political leaders, to get them to really think, how can PrEP fit into our prevention program, not to oversell it, but to really think how they can use this in the most effective way. Support for community advocates, and I think this is something we're all becoming aware of, that PrEP is going to be really driven by people in communities who feel that it's something important for their lives, which I think is, again, a really exciting thing about PrEP. It's galvanizing that community response, looking at medicines regulators so we can overcome some of the problems for drug purchase and distribution, public health officials to help them make good strategic choices about where PrEP could be used, clinical administrators, again, how would PrEP fit into a range of different clinical settings, clinicians, be they doctors, clinical officers, nurses, how they can provide PrEP safely, counsellors to support people who are considering PrEP and helping them to stay on PrEP, people in laboratories to help them with the lab tests required, pharmacists with the drug supply, and then really importantly, PrEP users. I think again we've learned so much along the way with HIV that people who have experience of services, have taken treatment, and now are taking PrEP are really important to engage and to support learning from how they want services delivered. What things they find useful and what things they find barriers. And then really looking at how we can show that a PrEP program works, and looking at how to evaluate and monitor programs. So that's the outline of the modules. And these are this is the way we're going to look at it. So we'll have how to engage leadership. So we'll have a module really to say what are the key issues that when we're talking to people in ministries that we need to get them to understand the benefits of PrEP. How to create awareness in the communities, and I think some communities are already very aware, and certainly amongst the MSM community. Often the MSM community is more informed than most of us, but other communities who could benefit, sex worker communities and women in high instance areas really need a lot of support to understand the benefits and the cautions with PrEP, and this feeds into how to create demand. When we talk to countries, they worry that the potential for offering PrEP could be enormous, and that they would be facing huge bills and huge logistic challenges. So we need to really help them how to start programs, how to prioritize, and where to deliver PrEP. This is going to vary from setting to setting, from population to population, country to country. So we need to explore what's going to be the best place to offer PrEP. And then we have a whole range of issues on monitoring, which we need to engage with clinical staff and laboratory staff. We know PrEP works. We have really very, very good evidence from a number of trials that if people take PrEP, it will prevent HIV. But we need to support people to it that's going to make it effective, so that they can adhere for the period that they need that protection. So we're going to need to engage with PrEP users and counsellors, and really to sort out how good does PrEP adherence mean, and what does that look like in a PrEP user. It's very different from treatment. You start treatment and you're going to have to take your antiretrovirals for your life, but with PrEP there will be periods you want to take it, periods you don't. You don't need it, and supporting people to come in and come off PrEP are really important. Drug regulatory issues, this is a minefield. And different countries are choosing different ways to overcome this, and this is something that really UNAIDS is working on to support countries to overcome regulatory issues. We need to use our PrEP advocates and PrEP users to involve and inform communities to make sure that services really meet their needs. And again, they are much better placed than people who are sitting back in offices to design PrEP programs. We must listen to communities and find out what they found important. Overcoming legal constraints in offering services is going to be a challenge in some settings, particularly for younger PrEP users. And then specific considerations for a range of populations. There are going to be different issues for adolescent girls and young women, for key populations, for serodiscordant couples, looking at people who've been taking PEP, for example, and want to transition into PrEP. And then how does PrEP fit in with family planning, particularly hormonal contraception? So I'm just going to give you a little sneak preview of what just a very few issues that and some of the modules that we're developing. And at the moment we have all our modules in draft. At the moment they are out for wide peer review, and We've got a fantastic response from peer reviewers giving us a lot of different information and advice and comments. So really we hope that this will be something that that we get right. As far as we possibly can, everything we say is built on evidence, from reviews, from the clinical experience we have from the trials and from ongoing projects and from client experience. We will be sharing the draft modules in Durban at the IAS, and we will then, after that, be able to finalise the toolkit, and it will be available. We're not going to put a date on this at the moment, but definitely by the end of this year, and we'll have it available in paper and electronic versions. Really importantly, PrEP in the real world is relatively new. So we plan regular updates when new evidence and new experience comes available. So these are going to be living modules. Key for in the kind of public health chapter is really how can we identify the populations at substantial risk, and we came to a conclusion, not a massively thoughtful conclusion, but based on some very basic costing data, that an incidence of about 3% would make PrEP cost effective, and that was certainly consistent to some extent with the US, where they suggest a 2 per 100 person years would justify PrEP in that setting. And if you look at the trials, most of the trials that looked at PrEP really found that they could find people who would benefit from PrEP in that above 2% and 3% incidence range. And when we look at data from studies, and this is work that Shona Dalal, one of our colleagues here, is working on, really looking at where these populations who have high incidence reside, and she's just been looking at data from Swaziland and from the SHINS data there, and really you can see that women in general across Swaziland have high incidence, but when you scroll down, you can see that being not married and having more than 2 partners increases that incidence to a significant degree. But what is really important is that while you do that, you also decrease the numbers. So it's a less frightening prospect for countries, that they can really start with trying to find the much smaller group who experiences highest incidence and would benefit most. If you look at data from South Africa and Kenya, you can see that on a general population level, both for men and women and the 2 age brackets, 15 to 24 and 15 and above, it's not going to be something that's going to be useful for the entire population. However, if we look more closely, and again look at 2 age groups, the 15 to 19-year-olds and the 20 to 24-year-olds. Here this is data from UNAIDS. You can see that as you're getting into the women in the higher age group, you're beginning to see instances that could warrant thinking about PrEP in these age groups. But it's very important to think that these are country data, and countries are very, very heterogeneous, not only by geographical area, but within populations within those groups. So we would anticipate that countries would look in a much more nuanced way at their epidemiology. So if considering PrEP, they would look at the counties, the districts with the highest incidence, and then within that population provide services for age groups and people with other characteristics out of school, more than 2 sex partners, who could maximally benefit from PrEP. In the clinicians chapter, which is really very nearly finished, we're just finalising that with the comments we're getting back. We're really just going through all the issues: what testing is needed, how frequently we should offer that testing, looking at the benefits of starting PrEP on the same day rather than delaying it, looking at all the pre-screening and monitoring that will be required during it as stream and safe as possible, but at the same time not really having any risks. And I think this is really important as we roll out PrEP to a more real world and to a wider population, that we must continue to make sure that it's done safely and monitor for any adverse events that we either anticipate or don't anticipate. And as I say, we're going to have we're going to note the different needs from different populations, particularly pregnant women, adolescent girls and young women, key populations. Here I should emphasise that our priorities really will be with men who have sex with men, with transgender populations everywhere, sex workers in countries that continue to show high incidence, so that's often in southern and eastern Africa. People who inject drugs, we're not prioritising that as a group for prevention of HIV through injection, given that we really prioritise harm reduction of that group. But we recognise that there is an overlap between drug use, be that injecting drug use or non-injecting drug use with HIV, particularly where this overlaps with other risk factors, and this is again a population that we need to have greater attention with. So I'm just giving you some screenshots here of some of the of how we lay out the PrEP clinicians chapter. Really, we've got little boxes of the key things and how to monitor the key messages that you give. So in summary, it's a work in progress. We will be sharing with this at IAS in draft form. We will have the real completed work soon thereafter. We really want to provide information for decision makers, the whole range of providers, PrEP users, and creators. And hopefully this will contain everything to make PrEP acceptable, safe, and effective. And we will continue to update this to make this relevant and improve this as we get more information. I really want to thank, and I put there in a light bulb as our kind of our guiding principle and our thought behind this, Bob Grant, who's really been hugely helpful in this and drafting the chapters and is working with WHO as a consultant to make sure that we get this right. My team here at WHO, my great colleagues, Ioannis, Michelle, Shona, Nathan Ford, Francoise, Lynn Moffison, who has been fantastic in supporting us in providing the evidence to show the safety of tenofovir-containing PrEP during pregnancy, and more than 90 peer reviewers who have given their time to really hopefully make this a great piece of work. Thank you very much, Carlos.
Thank you, Rachel. Thank you very much. Now we have Ioannis.
Thank you, Carlos. This is Ioannis. I'm an epidemiologist here at the HIV Department at WHO, and very much delighted to be participating in this webinar. I'm just going to shift gears a bit and give you an overview of a technical consultation we had a few months ago here at WHO in partnership with UNAIDS around the appropriate drugs for PrEP. We're actively finishing up the technical update report from that consultation, and so I really would just want to give you a bit of a glimpse into the methodology and also the key messages that are coming out from that consultation. So as Rachel set the scene with the rationale behind our enabling recommendation on PrEP from last year, I just want to bring up here on the slide the actual words to the recommendation itself. If you pay attention, the recommendation refers to the use of oral PrEP containing TDF, and that does not designate only tenofovir emtricitabine, TDF-FTC. And I will explain the implications of this in just a bit. So, but first, I think it's helpful to really highlight what we really aim to do here at WHO with our guidelines, and that really is taking the public health approach. I think it's also helpful to understand what we actually mean by that. It really is addressing the health needs of a population or the collective health status of a people, rather than thinking about individual case management. This approach aims to ensure the widest possible access to high-quality services at the population level. And specifically for HIV, the public health approach really consists of these elements: simplified drug formularies, large scale-up of using fixed-dose combinations across all age bands. Importantly, we look towards care and drugs being provided free at the point of service. And this is very much in the spirit of universal healthcare coverage, which is very much based in the WHO Constitution from 1948. Another key element to the public health approach for HIV is decentralization, and where possible, integration of services, including task shifting. And lastly, really looking at simplified approaches to clinical monitoring. Now, in terms of which countries have approved PrEP, the U.S. Is noted as being the first country to approve TDF-FTC back in July of 2012. This was done by the Food and Drug Administration in the U.S. In September of 2015, since we released the WHO recommendation on PrEP from last year, soon after, we've had a number of countries whose regulatory authorities have approved the use of PrEP. And all those have been specifically for TDF-FTC. Australia is the most recent addition to that list, again by the approval of TDF-FTC by their Therapeutic Goods Administration. And this happened earlier in May. So the U.S. itself has the longest programmatic experience with PrEP since the FDA approval, and there's an estimated number of 50,000 PrEP users in the United States. This is an estimate according to Gilead. France, being the only European country that has approved PrEP currently, has about an estimated 500 PrEP users since the approval there. And the take-home message from this slide is, in terms of scaling up PrEP, and Rosalind will speak to the UNAIDS targets in a bit, but the larger question is, can we actually get to 3 million PrEP users by 2020, as stated in the UNAIDS target? So that's a big question, and which brings us to the actual available drugs for PrEP. That are options in order to get to that target. So as I mentioned earlier, the 2015 WHO recommendation spells out oral PrEP containing TDF. So one asks, how do you actually interpret this? What does it actually mean? And are we talking about only TDF-FTC? And what about TDF alone? We want to be clear that the 2015 recommendation by WHO was based on a systematic review and meta-analysis of all the clinical trial evidence available to date. All these trials have looked at either TDF alone or the fixed-dose combination of TDF and FTC. And since the release of our recommendation, we've had a number of ministries of health, civil society groups, and other stakeholders working in HIV prevention that have approached us and have requested further clarification on this issue. And so our response to that request was to have this technical consultation in March. Again, in partnership with UNAIDS, we convened a group of scientific experts in HIV PrEP research, and also pioneers in the area of ARV pharmacology. And we looked at 3 specific issues. First, the possible use of lamivudine as an alternative to emtricitabine for oral PrEP containing TDF. Secondly, the possible use of TDF alone for oral PrEP. And we also looked at the safety of PrEP during pregnancy and breastfeeding. Rachel noted the work undertaken by Lynn Moffinson that really contributed to this, and she did a very comprehensive systematic review on the topic, and that data was presented at this consultation. So, in terms of implementation considerations, which Rachel well articulated just before me, I think it's just important to underscore that guidelines do differ between agencies such as WHO, CDC, and the European AIDS Clinical Society. In terms of, Rachel spoke to this, the complexity and cost, licensing, competing interests at a national level, and of course who and how to prioritize PrEP. And therefore, obviously, there's many challenges ahead, barriers, but opportunities as well. On this slide here, really, I think it's important to have a sense of what the treatment market looks like between TDF3-TC, TDF-FTC, and TDF alone. Most low middle-income countries, actually, more countries procure the combination of TDF3-TC in their treatment programs. But there's also a significant share of that is for TDF-FTC as well. The volume of single TDF that's being procured by national programs is quite small, and there's an estimate of about 100,000 people in low middle-income countries that are actually using TDF alone as part of their ART regimen. So the take-home message from this is that you have, some countries that currently within their procurement system, supply chains have TDF3-TC, others have TDF-FTC. So as part of our technical consultation, we looked at the spectrum of evidence, and we looked at animal studies, including studies from PK studies from animals, and also looking at virus challenge studies from the macaque models. And then we also looked at human data, and this human data was from, again, human pharmacology studies. We looked at RCTs, and in both TDF alone and TDF-FTC, for which there is data. To note, there is no clinical trial, and there's no study to date using TDF3-TC, although there's a pilot study that is looking at TDF3-TC and PrEP in Brazil. And we also considered systematic reviews and meta-analyses for both PrEP and ART in this review. In terms of looking at the safety of PrEP drugs in pregnancy and breastfeeding, we looked at pharmacology studies, ART studies. We also looked at the data from HBV treatment studies, since tenofovir is used in Hep B treatment, and this is a WHO recommended drug as well. There's limited data from PrEP trials, and so we examined that, and of course we also examined systematic reviews and meta-analyses. I think it's important to highlight that in our March consultation, first off, this was not a guidelines meeting; it was a technical consultation. And unlike in the WHO HIV treatment guidelines, where we make a distinction between preferred regimens versus alternative ones, in this consultation, we really considered the 3 drug options for countries, and really wanted to provide, in a very clear way, the direct and indirect evidence on the safety and efficacy for each of those drugs. And this was an approach, that we believe also helped identify where the research gaps are for each of the 3 drugs. So I think in terms of the working definition for direct evidence, direct evidence speaks to looking at evidence on safety and or efficacy of PrEP drugs that is generated from studies whose aim is to directly assess these outcomes of interest. And then in terms of indirect evidence, we're looking at the data from studies that where safety and efficacy is inferred. And so an example of this is looking at HIV treatment data, whereby we can make some inferences on the use of ARVs for prevention. We also have pharmacology studies in both humans and animals that provide insight, particularly in terms of penetration levels in the relevant tissue, specifically female genital tract, rectal tissue, and also penile tissue. And also the challenging studies are informative as well. And so, in terms of TDF3TC, the question that I have up here on the slide is there indirect evidence that shows that this combination could be considered as an option for countries to use for PrEP, especially where restricting PrEP drug choice to TDF-FTC would limit or prevent implementation. So, in other words, you have already TDF3TC on the shelves as part of your treatment program, and so could you, as a national program, consider the use of TDF3TC to start PrEP now and offer it to people at substantial risk for HIV in your country? And the answer to that is yes. And so, although the molecular structures of both drugs are similar, that doesn't necessarily equate into having the same efficacy in terms of preventing HIV infection. I think it's important also to note that there are considerable references in the literature that indicate that 3TC has a shorter half-life than FTC, and so that is something that is of concern and something that needs to be looked at much more carefully. It's also important to underscore that there is existing WHO guidance on what we call interchangeability of 3TC and FTC, with clear positions in the documents that I list here on the slide, and notably these are from the WHO PEP guidelines from 2014 and also our ART guidelines from 2015, where we are very clear that 3TC and FTC are interchangeable. And in terms of TDF alone, in our meta-analysis that led to the 2015 recommendation, we actually updated that analysis for the purposes of this consultation, and we actually examined the 10 studies that looked at TDF or TDF-FTC as PrEP. Interestingly, of all those studies, only one study has evaluated TDF PrEP in MSM. The majority of evidence has been generated across MSM, serodiscordant couples, heterosexual populations in general, with the use of TDF-FTC. So ultimately, we have only one safety study from the U.S. that has examined TDF for PrEP in MSM. And so one asks, TDF alone, does it work for PrEP? Of course it does. We have, in heterotransmission, we have Partners PrEP, which is a sort of our reference point on looking at the efficacy within heterosexual transmission. But it's trickier when you're trying to make inferences about the efficacy of TDF alone in MSM. And specifically, as far as that safety study that I mentioned, it was powered to look at. It wasn't powered to look at efficacy as an endpoint, but importantly, there were 0 infections after active TDF was administered in that group of men, while you had 7 infections in the deferred or placebo phase in that study. So, in terms of key messages, and as I mentioned, I'm sort of providing a bit. A preliminary insight into this work that we have been doing. Again, it's just important to underscore that the TDF-FTC itself has been used most widely in clinical trials, open-label extension studies, demonstration projects, and so the majority of the evidence on safety and efficacy for PrEP is based on this drug, and this goes for all populations: MSM, women, serodiscordant couples. However, the reality is that the cost of the originator product of TDF-FTC, particularly in some middle-income countries and even high-income countries, as in Europe, remains to be a barrier. And I believe Rosalind may speak to that a bit. And so, when you want to when considering only TDF-FTC for PrEP, this this could prevent potentially or limit a country's ability to start the strategic implementation of PrEP in order to address the ongoing HIV incidence, particularly in key populations. So just to highlight that the report that we're coming out from the March consultation will outline the data gaps for TDF3TC very clearly, and also for TDF. There are large potential gains in rolling out PrEP in populations, including certain pregnant women who remain at substantial risk for HIV. We recognize as WHO and UNAIDS that significant delays to such rollout will translate into new HIV infections and loss of life, and there are significant opportunity costs in delaying implementation of PrEP. In terms of what is next for us here at WHO, we are having a delegation that will be very active in Durban at AIDS 2016, and soon thereafter, or around that time, hopefully we'll have our technical report from the March consultation approved and published. In addition, we have our ongoing work in supporting member states in starting PrEP and scaling up. And of course, as all this implementation evidence is generated, we are going to have to revisit our normative guidance for updates. And as sort of my parting message is really in the context of the SDGs, is really to think about leaving no one behind as a guiding principle of our actions. And again, going back to what I mentioned earlier in my presentation, the public health imperative. And so I leave you with that. I would like to acknowledge our colleagues at the Centers for Disease Control in the U.S. and also UNC that were very much instrumental in helping us with our March consultation. Our colleagues at UNAIDS, of course, our WHO regional and country offices, and the Bill and Melinda Gates Foundation. So thank you, Carlos. Over to you.
Thanks very much, Ioannis, and we'll follow with Rosalind.
Thank you, Ioannis. Good morning, good afternoon, everybody. It's a pleasure. I'm very grateful to have the chance to participate. As we want to leave time for questions at the end, I'm going to maybe skip over a couple of slides so that I really talk to the things that are very specifically fall under UNAIDS remit. As Ioannis and Rachel both said, we collaborate with WHO under the same Bill and Melinda Gates Foundation grant. So I'm guessing that most of you know what the UNAIDS vision was back in a guiding vision of UNAIDS, and today I'm just going to speak to the first 4 of our mission that come in our mission statement about data, supporting countries, promoting and protecting human rights, and convening around the PrEP agenda. So this is the work that was done when we were coming towards the end of the setting the targets for 2015 about what could be achieved with ambitious fast-track scale-up. And the blue dots showing the number of new infections decreasing is what was modelled as being possible with ambitious scale-up of treatment and prevention. And the red dots is what would happen to the number of new infections if we just carried on with the status quo. So as you can see, there was an ambitious idea that if the fast-track interventions were rolled out, the number of new infections would decrease. Unfortunately, what we've seen more recently is that the number of new infections in adults is pretty static, is flatlining, and in some parts of the world the number of new infections is taking off, which gives us more impetus to our prevention revolution that we're planning, which of course will include PrEP. So this global AIDS update was produced a couple of months ago, and in there you will find more data, either driven by country or by population group, particularly about where these new infections are. So in the UNAIDS targets, there are several general targets that are relevant to prevention and to PrEP. I'm not going to read these out, but they are aiming for a high coverage of combination prevention across different groups that we know are particularly at risk of HIV. Like I say, I'm going to skip over the slides that I think you all know, but to emphasize that we're talking about PrEP's place in combination prevention. And these are now coming more specifically to the PrEP target that Ioannis mentioned, which is to have 3 million people on pre-exposure prophylaxis annually by 2020. So this target was based on reaching 10% of populations that were thought to be at increased risk. And this includes key populations, and then in countries where there is a very high incidence of population and age-specific high incidence, looking at those groups as well. And starting with 10%, it was the first time that a target's been made. And of course, we realized that not everybody in all these key populations is at substantial risk. We don't want to throw PrEP at everybody. For it to be to have an impact on the epidemic and to be affordable, then it needs to be, as Rachel was saying, very much given and help people to come who are at substantial risk to ask for it. So we need to remember that PrEP provision is really in its infancy. It's very variable across different countries. We're just beginning to think about the length of time for which people might take PrEP, when they might stop and restart. And for those reasons, we are learning as we go in terms of actually counting how many people are on PrEP. As Ioannis said, actually, the clinic base, including private clinics and the demonstration clinics, demonstration projects in the USA are dominating the numbers at the moment. But when it comes to measuring PrEP uptake, as I say, we hope to measure it per year. The main responsibility when UNAIDS is collecting its annual data is to ask the ministries of health to record this. And certainly in the USA, the manufacturer is collecting what are called new starts, when people have first started on PrEP. The Gilead figures that Ioannis quoted, the 50,000, do not include the demonstration projects. So our numbers are probably over 50,000, the number of people who are on PrEP. But we are right now starting a discussion of what the best way is to capture these numbers. And I'm sure most of you know about these two surveys that are going on PrEP in the wild, and also APCOM are running their own survey as well, trying to get a feel of people who are managing to access PrEP not through clinics or demonstration projects. So this is often online or through NGOs or through friendly doctors or through going back for monthly PEP prescriptions, but we're grateful to these surveys that are going on, trying to get a handle on that number of people taking PrEP not through clinical services. So this is just an overview of some of the big numbers that we do know at UNAIDS. We know that 112 countries are covered by the provision of generic TDF-containing products, either TDF FTC, where the license has been given to generic manufacturers, or TDF 3TC, which is not on patent at all. So out of these, no, not out of these, excuse me, in total 8 countries have a regulatory approval of PrEP, and 3 of them have national PrEP programs. And then from our country directors, our UNAIDS country directors, we have a feel that the interest in countries is going up. So, for example, from 19 countries in 2015 where it was reported that there was any discussion going on, in 1 year this has now gone up to 39 countries that are at least discussing PrEP to starting to consider putting it in national programs. 19 countries either have pilot or demonstration projects going on or are facilitating, for example, off-label use of PrEP in country. And 12 countries now say that they have PrEP in their national strategy, which we assume is going to lead on to development of PrEP within the national prevention program. We are challenged on sometimes on this target. Why aren't you going faster? Why aren't you aiming higher? And one of our mandates at UNAIDS is to keep human rights considerations at the front of all our work, and so we know that we are learning as we go along, and certainly when we're talking about providing to key populations in many situations, the legislative situation makes it extremely difficult for them to come forward if the services are not friendly towards them, and it can bring great risk to them. as well as, of course, in that situation, often having other competing interests. So we're learning how to bring PrEP to key populations, but also, of course, how to facilitate key populations coming to PrEP. These are the lessons that have been learned from PrEP rollout. I think these were mainly covered by Rachel and Ioannis. So in the interest of having some time for discussion, I want to finish off just by talking about the regulatory landscape that is confusing and opaque, I think we could say. To bring a framework of how to think about it, I would like to think of two rate-limiting considerations for bringing PrEP out. One is that within the country, the antiretroviral, whichever is chosen, as Ioannis went through the different options, has to be approved as prevention. And this can either be done by the regulatory body, the Medicines Control Council, or the Poisons Board, or whatever it's called in country, looking at the data and then making an approval for on-label use, if you like, for the use of the antiretroviral drugs as PrEP, or through the Clinicians Society advising that it is possible to use the drugs that are being used for treatment anyway in an off-label way of prevention. And off-label, this isn't the first time. It's not that PrEP is doing something new with this off-label use. In PNTCT, in PEP use, PEP use, and in new trials in cancer, infectious diseases, off-label use has been very valuable. But it isn't a long-term strategy. The aim is to bring medications on label eventually. And no regulatory authority is ever going to approve for off-label use. So this is an in-country decision that would need to be made. And the other rate-limiting factor is the cost, whether a country can buy the generic product. As we mentioned before, these 112 countries that are covered by license to be allowed to use generic TDF FTC. But in some middle-income countries, they are bound by the patent that if they want to use TDF FTC, they have to use from the originator. And that is when the option of TDF free TC, which is off-patent, could become interesting. In terms of, very briefly in the background, obviously if we're going to hopefully reach 3 million people with a new product, we have to be sure that the manufacturers are actually able to also meet that demand. And from a report that we've commissioned, it looks good. The ingredients that go into making these antiretrovirals should be available. It's possible that making the finished product will require, eventually when it comes to a scale of volume, a change of color and a change of packaging so that it doesn't look like treatment and that it's quite obviously something different from treatment or from recreational drugs as well. So in conclusion, to add to the conclusions that Rachel and Ioannis have also come with, we feel that PrEP rollout is feasible. The programs should be shaped with the priority populations, and that there are several different routes. If people have questions about that, then we can either answer them now, or please get in touch with us individually to ask more questions about the regulatory issues. These are the people I would like to thank. Joe Fortunac, who has had many discussions and explained to us the intricacies of the regulatory landscape. My UNAIDS colleagues and WHO colleagues, Eileen Corenromp and John Stover from the Avenir Centre, who helped UNAIDS with the original modelling, and the many civil society associations and PrEP users online who have helped us to think these issues through. Thank you very much.
Thanks very much, Rosalind, and to the three of you. And I wanted to actually, I think there will be some questions there, but just to start, what about the decision to establish targets? No, and usually we establish targets, but given that it's difficult to, I mean, as you, Rosalind, have outlined very well, there are so many complexities in defining a PrEP program in terms of people, I mean the target population, who needs it within the target population. In principle, the regulatory aspects, pricing, etc., how to set up a program that is government sponsored versus other kinds of programs, etc. So is it, I mean, the best way to go to use targets? That's the first question.
Thank you, Carlos. We feel that that having targets gives people something to aim for. It's aspirational. It encourages people to actually collect this data. Otherwise, without targets at all, it would be very difficult to know if we were making any progress or if the programs were actually the appropriate programs. It's not really a question of winning or losing, but it's more a way of monitoring progress. We've now triangulated these targets back with the 3% incidence that Rachel mentioned, and we feel that they are reasonable. Definitely we're learning as we go along, and one of the nuances that probably won't be captured by measuring just blunt targets is which populations are being reached, and that's going to be a question of measuring in country, individual countries, which populations are being reached, the effect of PrEP, the impact it's having, the number of seroconversions, any resistance that comes up in seroconversions. Those kind of nuances are not captured in a target, but we do feel it's important to have something to aim for and something to measure our progress against.
Mm-hmm. Okay, if Ioannis or Rachel want to say something, of course, you're welcome. There's another question just now about the fact that the US FDA usually, in terms of what drug to use, has a role for many countries, and I mean, it's a US FDA, of course, no, but have you received feedback from other institutions in relation to the idea of using other drugs besides TDF-FTC?
So I'll start this one. Yes, certainly FDA is used as a reference point for many settings. It's interesting that the PEPFAR Scientific Advisory Board, which gives the advice for PEPFAR projects, didn't follow that FDA advice and was much more enabling. And I think, you know, we haven't finished our report. What Ioannis was presenting is very much in our thinking at the moment, and it's not final. And I think countries will have to really make decisions based on their own environments, and if the only alternative to supporting PrEP is because of cost issues and because of supply chain issues, is to consider other regimes, this will be something that they have to consider on a country by country basis.
Mm-hmm.
The FDA is what's called a stringent regulatory authority, and so is Australia and France, out of the regulatory authorities that have approved PrEP. And they have to look at all the data from the phase 1 studies, the animal studies, etc., and add it all up. And at the moment, the only drug for which that exists is the TDF-FTC combination. So we're hoping, as more evidence comes through on TDF-3TC, that eventually the stringent regulatory authorities would be able to look at that as well.
Mm-hmm. Thank you, Rosalind. I also just wanted to comment that the Gilead has submitted a dossier to the European Medicines Agency a few months ago, and we're waiting for approval by the EMA, potentially, I don't know, by September, October of this year, on whether or not they will have a prevention indication. And I think that will also be very important and inspiring adoption of PrEP by by EU countries. But in I think sort of Rachel and sort of well pointed out the barriers, you know, related to cost and supply chain, you know, that many countries experience. That said, it's important to also note that Gilead has a licensing agreement, which Rosalind also noted. There are low middle income countries, 112 of them, that actually have access currently to generic TDF-FTC. So I think that's important to note.
Mm-hmm. Just we are I mean, we should end soon, but there were a couple of questions. One is actually about the approval in France of intermittent or on-demand PrEP, and whether or not WHO has decided anything about it or any other country would. And the other one is actually about mechanisms or support bodies that could become available for countries to implement PrEP, in the event they decided to do so.
So I'll answer the intermittent PrEP one. The impressive results from Baggaley show that event-driven PrEP does work very well for MSM in Paris, and certainly, I think what we can draw from that was a high amount of PrEP was taken because there was a high number of sex acts that were covered during the period. Now, we've also been aware that there haven't been any studies in women. There's only been the study in a high-income setting with an educated population, and certainly from the Project Adapt study, we were concerned that people from other settings found it actually easier to fit in their lifestyle to take daily PrEP. So at this stage, we really have been focusing on the daily PrEP. And I think we have to be careful, again, around language here, because I think it is confusing, and this is something that we go back to with countries. That they want something that's going to be very easily understood by their providers and by the people who take PrEP. And at the moment, I think people feel much more comfortable with an oral PrEP regime, but also understanding that that PrEP isn't for life, and I think it's a different concept. But the idea that one can take it for a period when one's at risk and then stop on an oral daily regime, stop and then restart should be something that should be encouraged. And I think we need to get that language, because I think there's a lot of confusion in countries that intermittent PrEP means something different in different contexts. And so, but certainly for the actual, very short spells of blips of PrEP around your sexual risk is something that we're not recommending at the moment. But we know there are trials going on for women, and we will definitely keep a watch on experience and data as it comes. Which is really why I said we're going to keep this as a living piece of work.
Mm-hmm. And just there was this other question about mechanisms in place to support countries where a decision may be adopted for PrEP implementation.
So, well, we as WHO are often called on by ministries of health to go and support them while they're considering a PrEP program, really at that first stage where they're thinking about where they should prioritize PrEP, how they should deliver it, which populations, and all the issues around monitoring. We hope our implementation guidance will support them with the nitty-gritty of all that, all the details. But both WHO and a range of other organisations and players and the other thing that we really hope to support is cross-country learning, and that's something that we are supporting in a couple of countries at the moment. Actually, one country is visiting another's PrEP program in Southern Africa, really to see, and I could see this as being really helpful to get countries, to start. And I think we mustn't underestimate in the kind of the PrEP world that there are a lot of concerns in ministries about. This is new. They're not familiar with it. They're also already struggling with a big treatment program, so that they will need a lot of support and a whole range of players to provide that.
Carlos, I just also wanted to comment. I think there are also lessons learned from the experience in scaling up male circumcision, and I think we all recognize that since we're in the infancy of global PrEP implementation, as we move outside of the U.S. and into sub-Saharan Africa, your region, and other settings, that we're trying to have a much more coordinated approach amongst global stakeholders, and how that sort of trickles down to regional players and ultimately at the country level. So, I mean, I think that's where we're at.
Mm-hmm. Okay. Well, excellent. I think we need to end now. Actually, but it has been.
I just want to make sure. I'm sorry, Carlos. I just see, just because, you know, in terms of our due diligence, and I just see a lot of sort of questions that are up there related to you know, the data that is available, you know, from particular studies, and I I don't want to sort of not address those, and so maybe we can, you know, we can just keep that. We've itemized those, and we can address them systematically to your audience if you want after the webinar.
Excellent, excellent.
Great.
Yeah, I felt that it had been already addressed. So excellent. Thanks very much to the three of you for your excellent presentations. I think we all have a much better idea of where things are at this point, because this is a very rapidly evolving field. I mean, so many studies and publications coming up very quickly. So it's really difficult to keep updated on everything. It's very important to have you, for us to. It was very important for us to have you guys here, and we'll upload this. I mean, the recording of this session very soon, either later today or tomorrow, and we'll keep in touch. Thanks very much again, and thanks to you all participants for your participation today. Thank you then.
Thank you, Carlos.
Thank you very much.
Bye. Bye. Thanks.
Bye-bye.